I was a bit tired, so I took a nap, basically. Yeah, and we're back for a fresh start, like we said at the end of the previous episode. Let me just check that our live stream is going good, and we'll get at it.
Welcome back. It's great to hear you're feeling refreshed. Ready to dive into homeostasis and general anatomy? Great to hear you're feeling refreshed. Ready to dive.
Okay, sounds good.
Awesome. Where do you want to start?
Alright, we left off, if you can see here, guys, this is episode 2. We left off trying to understand the coagulation factors involved with the prothrombin group, and the thrombin group, and I didn't really understand what was going on there, to be honest.
No worries. So the prothrombin group mainly includes factors like prothrombin, which is factor 2, and factor 10. These are crucial for forming thrombin, which then converts fibrinogen to fibrin to form clots.
Yeah, but what about 7 and 9?
Sure. Factor 7 plays a role in initiating the clotting process, especially in the extrinsic pathway. Factor 9 is part of the intrinsic pathway, working with factor 8 to activate factor 10.
Yeah,
Both
but
are key for...
why would we say that factors 2, 7, 9, and 10 have to do with the prothrombin group? Yeah.
They're grouped together because they're all vitamin K dependent and essential for the synthesis of prothrombin. This dependency links them functionally in clotting.
Okay, I see. And do they require calcium activation?
Yes, calcium is crucial. It helps these factors bind to phospholipid surfaces, which is necessary for the clotting cascade to proceed.
Okay. And then thrombin activates 1, 5, and 8, basically.
Exactly. Thrombin activates factors 5 and 8, which then amplify the clotting process. Factor 13 is also activated, stabilizing the clot by cross-linking fibrin.
What's factor 1?
Factor 1 is fibrinogen. It's the protein that gets converted into fibrin by thrombin, forming the mesh that stabilizes the clot.
Yeah, that makes sense.
Great. Anything else you'd like to explore about clotting?
Yeah, let's talk a bit more about vitamin K.
Sure. Vitamin K is essential for synthesizing clotting factors 2, 7, 9, and 10. It helps these factors bind calcium, which is necessary for their function in clotting.
One more time with vitamin K.
Vitamin K is crucial for activating clotting factors by enabling them to bind calcium, which is essential for the clotting cascade.
Just a sec.
Take your time.
Sorry guys, I just double checked the audio for a sec.
No worries.
Yeah, tell me again. Okay. Sorry, tell me again.
No problem. Vitamin K is crucial because it activates clotting factors by enabling them to bind calcium. This is essential for the clotting process to work properly.
And it's a fat soluble vitamin.
Exactly. It's fat soluble, which means it's absorbed along with dietary fats and stored in the liver.
Interesting.
All good?
And what in its structure makes it fat soluble?
Its structure includes a long, hydrophobic side chain, which allows it to dissolve in fats and oils.
So Okay. And the prothrombin stuff we said are involved with it.
Right. The prothrombin group, including factors 2, 7, 9, and 10, all rely on vitamin K for their activation.
But what specifically in their structure makes them connected to vitamin K?
It's the presence of specific amino acid residues, like glutamate, that vitamin K carboxylates. This modification allows the factors to bind calcium, crucial for their function.
So there's certain amino acid residues that vitamin K carboxylates, such as glutamate, and is that right?
Exactly. Vitamin K adds a carboxyl group to glutamate residues, which enables the clotting factors to bind calcium effectively.
So they can bind with calcium. And why do we want calcium binding?
Calcium binding is essential because it allows these factors to attach to cell membranes where the clotting reactions take place. This localization is crucial for efficient clot formation.
Tell me again why we need calcium, and also it's gamma carboxylation, but what is gamma?
Calcium binding is essential because it allows these factors to attach to cell membranes where the clotting reactions take place. Does that clear things up?
No, I'm a bit confused. Sad.
It helps, which is necessary for them to function in clotting.
Tell me again, brother.
All right, gamma carboxylation adds a carboxyl group to glutamate's gamma carbon, allowing clotting factors to bind calcium, which is vital for clot formation.
That makes sense.
Awesome. Glad it's clearer now.
It is clear.
Great. What's next on your list?
Well, I wanted to talk a bit about drugs like rivaroxaban.
Sure. Rivaroxaban is an oral anticoagulant that works by inhibiting factor 10A, preventing clot formation. Anything specific you want to know about it?
Well, yeah. So you said it prevents clot formation. How does it do it?
Rivaroxaban specifically targets and inhibits factor 10A, an enzyme crucial for converting prothrombin to thrombin. By blocking this step, it reduces thrombin formation, which is essential for clotting.
Clotting factor 10A. Wow, interesting. Now I want to go a bit in the etymology of rivaroxaban. I don't understand why it's called that. Etymology of rivaroxaban, please.
The name rivaroxaban combines riva, possibly from rival or river, suggesting movement, and oxaban, a suffix used for 10A inhibitors. It signifies its function as an anticoagulant.
Specifically, it's used to treat deep vein thrombosis and pulmonary emboli.
Exactly. Rivaroxaban is often prescribed to prevent and treat deep vein thrombosis and pulmonary embolism by inhibiting clot formation.
Inhibits factor XA, the prothrombinase. What's a prothrombinase complex?
The prothrombinase complex is a group of proteins, including factor 10 and factor 5, that converts prothrombin into thrombin.
Okay. By the way, sorry guys, there's a bit of noise outside, like a white noise almost, from some ventilation machine. So I'm so sorry. I might have to relocate in the future. When I say relocate, I mean probably just move my desk on the other side of the room. But yeah, sorry, ChatGPT. Tell me again. So, what's the prothrombinase complex?
No worries. The prothrombinase complex is made up of factor 10A, factor 5, and calcium ions. It assembles on cell membranes and converts converted prothrombin into thrombin.
I see.
A key step in...
That makes sense.
Awesome. Glad it's clear now.
Yes, sorry. Yeah, so rivaroxaban indeed makes sense.
Great. Anything else you'd like to dive into?
Yeah, fibrinolysis.
Sure. Fibrinolysis is the process where clots are broken down. It's mainly carried out by an enzyme called plasmin, which digests fibrin.
So plasmin digests fibrin?
Exactly.
Okay. And so I assume we have plasminogen too.
Exactly.
And why did we choose plasmin digesting fibrin and not choose the name fibrin to digest plasmin?
It's all about function. Plasmin's job is to break down fibrin, not the other way around.
Yeah,
The name
dude, but
reflects its role.
why? I mean, okay, how does the name reflect the role?
Plasmin means it acts on plasma proteins, like fibrin. The in suffix often indicates an enzyme, so it's named for its action.
Interesting. Okay. And we need TPA too, right?
Yes, TPA is crucial because it activates plasminogen to plasmin, initiating fibrinolysis.
Nice. Wow, we have inhibitors too.
Yes, there are inhibitors like plasminogen activator inhibitor 1 that regulate this process, ensuring clot breakdown doesn't happen too quickly.
So cool.
It really is. The body's balance mechanisms are fascinating.
Nice. Okay. So is this a protein, plasmin and fibrin?
Yes, both plasmin and fibrin are proteins. Plasmin is an enzyme.
Any other proteins? Any other proteins?
Exactly. There are plenty, like antithrombin, protein C, and protein S, which regulate clotting and ensure balance.
What's protein C? He's being shy, guys. Let's start anew. Sir, what's protein C?
C-reactive protein, or CRP, is a substance produced by the liver in response to inflammation. It's commonly measured in blood tests to help detect inflammation or infection.
I'm not sure if we're talking about the same one. I think protein C is a coagulation inhibitor.
Ah, got it. Protein C is a natural anticoagulant that helps regulate blood clotting. It works by inactivating factors VA and 8A, which slows down clot formation. Deficiencies in protein C can lead to an increased risk of abnormal blood clots.
Factors VA and 8A?
Yup, exactly. Factors VA and 8A are part of the coagulation cascade. Protein C, along with its cofactor protein S, helps to inactivate these factors, preventing excessive clot formation. This balance is crucial for normal blood clotting and preventing conditions like thrombosis.
3 and 7 is extrinsic, right?
Right. Factors 3 and 7 are also crucial in the clotting cascade. Factor 3, or tissue factor, initiates the process by activating factor 7. This combination triggers the clotting cascade.
Yeah, is it extrinsic or intrinsic?
Factor 3, or tissue factor, is part of the extrinsic pathway.
Yeah.
It kicks off the clotting process when there's tissue injury by binding with factor 7.
Okay, let's go back to protein C. So it's a coagulation inhibitor, and is it active?
Yes, protein C is active when it's converted to its activated form, known as activated protein C, or APC. This activation happens through a complex with thrombin and thrombomodulin. Once activated, it helps to degrade factors VA and 8A, reducing clot formation.
So it has to go from inactive to active. What's the name of the inactive and what's the name of the active form?
The inactive form is just called protein C. Once it gets activated, it's referred to as activated protein C, or APC.
So 5A and 8A, I don't understand why they inactivate specifically 5A and 8A. And don't give me a generic answer such as, well, because of the structure. Well, what about their structure makes them ideal?
All right, let's dig into it. Factors VA and 8A are critical because they form complexes that significantly accelerate the clotting process. Factor VA combines with factor 10A to form prothrombinase, while factor 8A pairs with factor 9A to form 10ase. APC inactivates them, slowing down these reactions, which is crucial for controlling clot formation.
Wait, 5A combines with 10A and 8A with 9A?
Yup, that's correct. Factor VA forms a complex with factor 10A, which is called the prothrombinase complex. Factor 8A combines with factor 9A, forming the 10ase complex. Both are essential for accelerating the clotting cascade.
So 8 and 9A 10A's and 5 and 10A?
Exactly. 10ase refers to the complex of factor 8A with factor 9A, and prothrombinase is the complex of factor VA with factor 10A. These complexes are crucial for efficiently converting prothrombin to thrombin in the clotting process.
And what about protein S?
Protein S is a cofactor for activated protein C. It enhances the ability of APC to inactivate factors VA and 8A. Essentially, protein S helps ensure the anticoagulant effects of protein C are efficient.
Tell me more.
Sure. Protein S not only acts as a cofactor for APC, but also has some direct anticoagulant properties. It's essential in preventing excessive clotting and maintaining the balance in the coagulation system.
I'm a bit confused.
No worries. Simply put, protein S supports activated protein C in its job of slowing down clot formation. It also has its own mild anticoagulant effects, helping to keep the clotting process in check.
Protein is partly homologous due to other vitamin K dependent plasma coagulation proteins such as protein C and factors 7, 9, and 10.
Exactly. Protein S, like protein C and factors 2, 7, 9, and 10, is vitamin K dependent. This means it requires vitamin K for its synthesis and function. This group of proteins plays key roles in coagulation and anticoagulation.
I don't understand it, I can't lie.
That's okay. The key point is that protein S, like some other clotting factors, needs vitamin K to function. This dependency...
What about antithrombin 3 and heparin?
Antithrombin 3 is another important anticoagulant. It inhibits thrombin and other clotting factors. Heparin enhances the activity of antithrombin 3, making it a powerful anticoagulant used clinically to prevent and treat clots.
Tell me a bit more about this.
Sure. Antithrombin 3 neutralizes several enzymes in the clotting cascade, especially thrombin and factor 10A. Heparin boosts its effect by increasing the rate at which it inactivates these clotting factors, making it useful for preventing blood clots.
I don't understand.
No problem. Think of antithrombin 3 as a natural brake on clotting. Heparin acts like a helper, boosting antithrombin's ability to inhibit clotting factors.
Do we have antithrombin 1 and 2?
Actually, antithrombin is typically referred to as antithrombin 3. The numbering is a historical artifact. There aren't antithrombin 1 or 2. The name antithrombin 3 stuck, but it's the main antithrombin protein in the body.
Well, what does the number 3 say?
The 3 in antithrombin 3 refers to an older classification system for plasma proteins. It doesn't imply there are antithrombins 1 or 2. It's just
Tell us about this older classification system.
The older classification system categorized plasma proteins based on their functions and how they were discovered. Antithrombin 3 was named because it was the third antithrombin activity identified, even though it's the primary one.
Well, what's the first and second antithrombin activity do?
The first and second antithrombin activities were more general terms used historically for proteins that inhibited clotting. Today, these aren't separate proteins, but rather aspects of the broader inhibitory actions of antithrombin 3. They all refer to its ability to neutralize different clotting factors.
Antithrombin is a small glycoprotein that inactivates several enzymes in the coagulation system.
Exactly. Antithrombin is a small glycoprotein that plays a crucial role in regulating coagulation by inactivating several enzymes.
The designations antithrombin 1 through to antithrombin 4 originate in early studies carried out in the 1950s by Seegers, Johnson, and Fell.
That's right. Those designations came from early research that identified different inhibitory effects on clotting factors. Over time, these were unified under this single term, antithrombin 3, reflecting its broad role in the coagulation system.
Interesting. Okay, and how's heparin involved then?
Heparin binds to antithrombin and causes a conformational change that greatly increases its ability to inhibit thrombin and factor 10A. This enhanced activity makes heparin a powerful anticoagulant used in medical settings.
I see.
Exactly. It's a key part of how heparin works to prevent blood clots.
Okay, that makes sense. So, blocks the activity then of 10A and 9A, right?
Yes, exactly. Heparin through antithrombin mainly blocks the activity of factor 10A and thrombin. Factor 9A is also inhibited to a lesser extent.
Okay. How can we reverse heparin?
Heparin's effects can be reversed using protamine sulfate. Protamine binds to heparin, neutralizing its anticoagulant effect, which is useful if there's a risk of bleeding.
Okay. And so if I have deficiency of antithrombin 3, what happens?
A deficiency in antithrombin 3 increases the risk of abnormal blood clots, such as deep vein thrombosis or pulmonary embolism. It means your body's natural ability to control clotting is reduced.
Okay, so we talked about some different ones, if I'm not mistaken. We've talked about heparin and antithrombin 3 and protein S and protein C, and we talked about plasmin, and I want us to put all of these together so we don't get confused in terms of which factors they affect.
Sure, let's break it down. Heparin boosts antithrombin 3, which inhibits thrombin and factor 10A. Protein C, with protein S as a cofactor, inactivates factors VA and AA. Plasmin, on the other hand, breaks down fibrin clots. Each one plays a role in balancing clot formation and breakdown.
Okay, I'll attempt to say it again. So heparin and antithrombin 3 is 9A and 10A.
Close. Heparin and antithrombin 3 mainly target thrombin and factor 10A, with some effect on factor 9A. Great job summarizing.
And then protein C and protein S?
Yes, protein C with protein S as a cofactor inactivates factors VA and AA. They slow down the clotting process to prevent excessive clot
It's gonna be
formation.
so hard for me to remember all of these specific things, dude.
It can definitely be a lot to take in. Maybe try breaking it down into smaller parts or using mnemonic devices to help. Repetition and association.
Is there like a diagram with everything together that we could use?
Yes, diagrams can be super helpful. You can find coagulation cascade diagrams that map out these interactions. They visually show how each factor and inhibitor connects, making it easier to remember.
Yeah, I'm gonna try this now.
Great idea. Visual aids can be a game changer. Enjoy exploring it.
Oh yeah, this seems like a good one.
Glad to hear
Dr. Graham Beards. Shout out. Okay.
Absolutely.
Let's see.
Anytime. Take care.
So we've got the, let's see, we've got, well, what's the end goal of the blood coagulation?
The end goal of blood coagulation is to form a stable clot that stops bleeding. This process seals damaged blood vessels, preventing excessive blood loss and allowing for tissue repair.
So a stabilized cross-linked fibrin clot.
Exactly. The final product is a stable, cross-linked fibrin clot that reinforces the platelet plug.
Yeah. Okay, that makes sense. So, basically, in order for that to happen, first fibrinogen has to become fibrin, prothrombin, thrombin. I think we figured that part out. And then, if we go backwards, the other part I'm really confident with is I understand that 10 has to become 10A. Although I wonder the reason that 10 has to become... I wonder the reason why 10 is the specific one. What in the structure of 10 makes it good for its role?
Great question. Factor 10 is crucial because its active form, factor 10A, is a key enzyme in converting prothrombin to thrombin. Its structure allows it to interact efficiently with other coagulation factors, making it central to the clotting cascade.
Okay, so then when fibrinogen becomes fibrin, how is factor 8 involved?
Factor 8 acts as a cofactor in the tenase complex, which includes factor 9A. This complex is crucial for activating factor 10 to 10A, ultimately leading to fibrin formation.
Okay, wait a second. So we have thrombin, and it says that thrombin helps 8 to become 8A.
That's correct. Thrombin activates factor 8 to 8A. Activated factor 8 then combines with 9A to form the tenase complex, which is essential for amplifying the clotting cascade.
Okay, so 8 to 8A, which combines with 9, and so that becomes 9A. Also, antithrombin, how is it involved in this?
Exactly. 8A combines with 9A to form tenase. Antithrombin then acts by inhibiting thrombin and factor 10A, helping to regulate and limit clot formation.
And then 7 becomes TF7A. What's that?
Factor 7 combines with tissue factor, TF, to become 7A, forming the TF7A complex. This complex initiates the extrinsic pathway, kicking off the clotting cascade by activating factor 10.
But this is the extrinsic one.
Yes, that's the extrinsic pathway. It starts with tissue factor and factor 7A, leading to the activation of factor 10.
Okay, let's talk a bit about vitamin K deficiency.
Sure. Vitamin K is essential for synthesizing several clotting factors, including 2, 7, 9, and 10, as well as proteins C and S. A deficiency can lead to impaired clotting and increased bleeding risk.
2, 7, 9, and 10.
Exactly. Those are the vitamin K-dependent clotting factors. Without enough vitamin K, their production is reduced, which can affect proper blood clotting.
Guys, give me 20 seconds, just a 20-second break, catch your breath, and I'll be back.
No problem. Take your time.
Alright. So, let's continue. So, Vitamin K deficiency. We said that 2, 7, 9, and 10 are the ones that are affected because of the glutamate, I think. Yeah, so we will have problem with clotting then.
Exactly. Vitamin K is essential for adding a carboxyl group to glutamate residues in these factors, enabling them to bind calcium and function properly. Without that modification, clotting is impaired, leading to bleeding issues.
How is vitamin K made?
Vitamin K is obtained from two main sources: leafy green vegetables and gut bacteria. The body can't produce it on its own, so a balanced diet and healthy gut flora are important for maintaining adequate levels.
And these bacteria, where are they?
They're primarily found in the large intestine. These bacteria synthesize vitamin K, which the body can then absorb and use for clotting factor production.
Why large intestine and not small intestine?
The large intestine hosts a diverse, dense population of bacteria, creating an environment where vitamin K producing bacteria thrive. While some absorption happens in the small intestine, the majority of bacterial synthesis occurs in the large intestine.
Why large intestine and not small intestine? And then also, if something goes wrong, we have a GI disease, we're gonna have problems then.
Exactly. If there's an issue in the GI tract, like a disease or disruption of gut flora, it can reduce vitamin K production and absorption. This can lead to clotting problems, so maintaining gut health is important.
Interesting.
If a
So, for instance, if you have a GI disease, how will the problem be? Is it because of no absorption?
Yes, that can be a factor. GI diseases can impair absorption and disrupt gut flora, reducing vitamin K production. This can lead to deficiencies and problems with clotting.
How does something like warfarin work then?
Warfarin works by inhibiting vitamin K epoxide reductase, an enzyme needed to recycle vitamin K. This reduces the activation of vitamin K-dependent clotting factors, thinning the blood and preventing clots.
Interesting. And how come we named it warfarin then?
The name warfarin comes from its development by the Wisconsin Alumni Research Foundation, WARF, and its chemical structure as a coumarin derivative. It's a blend of warf and coumarin.
Interesting. So, hemophilia, I mean, very related to what we're talking about. We already mentioned it. We've got A and B. Start talking about it, please.
Sure. Hemophilia is a genetic disorder where blood doesn't clot properly. Hemophilia A is due to a deficiency in factor VIII, while hemophilia B involves a lack of factor IX. Both result in prolonged bleeding.
So, deficiency factor 8, B is deficiency factor 9. And which one is worse?
Hemophilia A caused by factor VIII deficiency is more common. Hemophilia B due to factor IX deficiency is less common, but clinically similar. Both can range from mild to severe.
Which one is more common?
Hemophilia A is more common than hemophilia B. It accounts for about 80 to 85% of hemophilia cases.
Interesting. Okay. And so hemophilia is hemophilia A, is it sex linked?
Yes, hemophilia A is a sex-linked disorder. It's caused by a mutation on the X chromosome. Since males have only one X chromosome, they're more likely to be affected if they inherit the faulty gene. Females can be carriers if one of their X chromosomes carries the mutation, but they're less often affected.
Interesting.
You're welcome.
Can we inject factor 8 then?
Yes, definitely. People with hemophilia A often get injections of factor VIII to help their blood clot properly. This treatment can be given on a regular schedule or when there's a bleeding episode.
Is it common?
Hemophilia A isn't super common, but it's also not extremely rare. It affects about 1 in 5,000 male births. The severity can vary a lot too, depending on how much
Yeah,
factor
but
VIII
no, I
occurs.
mean injecting with factor 8 sounds something expensive, dude.
Yeah, it can be pricey. Factor VIII treatments are expensive, especially if you need them regularly. Costs vary depending on where you are and your healthcare coverage. Some countries have support programs to help manage those expenses.
Interesting. Okay, so what's the difference of clotting and atherogenesis then?
Great question. Clotting is the normal process where blood thickens to stop bleeding after an injury. Atherogenesis, on the other hand, is the formation of plaques in the arteries, which can lead to narrowing and hardening of the arteries, contributing to cardiovascular diseases.
Formation
They're
of
related.
plaques.
Yeah, exactly. Plaques are made up of fat, cholesterol, and other substances. Over time, they can build up and restrict blood flow, which can lead to...
So fibrin mesh is not a plaque?
That's right. A fibrin mesh forms during clotting to stop bleeding. It's a network that traps blood cells to create a clot. Plaques, on the other hand, are fatty deposits in artery walls. So, they're different processes, but both involve blood components.
Fatty deposits, and you said that we have cholesterol too.
Exactly. Cholesterol is a major part of those fatty deposits. When there's too much in the blood, it can accumulate in the artery walls, contributing to plaque formation. It's a key player in atherogenesis and why managing cholesterol levels is important for heart health.
Can we go a bit deeper into atherogenesis?
Sure. Atherogenesis starts with damage to the inner lining of arteries, often due to high blood pressure, smoking, or high cholesterol. This damage allows cholesterol to enter the artery wall, triggering an inflammatory response. Over time, immune cells, like macrophages, try to clear this cholesterol, but end up forming fatty streaks that develop into plaques.
So we have just a sec. I'm just pulled up the Wikipedia page. So we have monocytes and macrophages involved.
Yes, monocytes from the bloodstream enter the artery wall, turning into macrophages. They gobble up cholesterol, becoming foam cells, which eventually form part of the plaque.
So monocytes enter, they become macrophages, and then the macrophages, what do they do?
Once monocytes become macrophages, they engulf the cholesterol, turning into foam cells. This buildup contributes to plaque formation.
So when they engulf cholesterol or cholesterol esters?
It's mainly cholesterol and cholesterol esters. The macrophages ingest these, becoming engorged foam cells. This process is a key step in the development of atherosclerotic plaques.
So what's the difference between cholesterol and cholesterol esters?
The main difference is in their structure and function. Cholesterol is a free molecule, while cholesterol esters are cholesterol bound to a fatty acid. Cholesterol esters are stored in cells and transported in the blood, while free cholesterol is involved in cell membrane structure and other functions.
Interesting. So then after they engulf this cholesterol, they become foam cells.
Exactly. Foam cells are basically macrophages loaded with cholesterol. They look foamy under a microscope. These foam cells accumulate in the artery walls, contributing to plaque growth and the progression of atherosclerosis.
Interesting. And what happens after then?
Well, over time, those foam cells can die, releasing their contents and contributing to the lipid core of the plaque. This can cause the plaque to grow and potentially become unstable, leading to complications like a heart attack if it ruptures.
Interesting. So does this attract other chemicals?
Absolutely. Inflammatory chemicals and immune cells are drawn to the area, worsening the inflammation. This can further destabilize the plaque, increasing the risk of rupture and serious events like heart attacks.
Why does it attract them?
It's mainly due to the body's inflammatory response. The immune system sees the plaque as a problem and sends cells and chemicals to try to fix it. But this response can actually make things worse, leading to more plaque growth and instability.
Can you remind us, since we're on the topic about LDL and HDL and how they're connected?
Sure, LDL, or low-density lipoprotein, is often called bad cholesterol because it can deposit cholesterol in artery walls, contributing to plaque formation. HDL, or high-density lipoprotein, is known as good cholesterol because it helps remove cholesterol from the bloodstream, transporting it to the liver for elimination. Balancing these levels is crucial for heart health.
What do you think is the best encyclopedia ever existed?
is amazing for quick, accessible info. For depth, some might say Encyclopedia Britannica or the Oxford English Dictionary are top contenders. Each has its strengths.
Wikipedia, I think, is the best. Well, I don't know, but it seems to me that it's really good.
Wikipedia is definitely a fantastic resource. It's comprehensive, constantly updated, and free. Its strength is in the sheer volume of topics and the collaborative nature of its content. Plus, it's accessible to everyone.
Yes. Okay, so so how? Let's talk a bit more about atherogenesis and cholesterol esters, this kind of stuff.
Sure, cholesterol esters are stored in foam cells, and when these cells die, they release their contents into the plaque's lipid core. This enlarges the plaque and can lead to a fibrous cap forming over it. If the cap ruptures, it can cause a blood clot, which might block the artery.
Does cholesterol get oxidized?
Yes, it can. Oxidized LDL is particularly harmful. It's more easily taken up by macrophages, accelerating foam cell formation.
Explain this part to me a bit more.
Sure. When LDL gets oxidized, it changes chemically. This altered form is more likely to be recognized by macrophages, which then engulf it.
How does it become oxidized though?
It happens through reactions with free radicals in the body. These are unstable molecules that can damage cells and other substances, including LDL. Factors like smoking, pollution, or even normal metabolic processes can produce these radicals.
And when these radicals are produced, what's the problem?
It's a problem because these free radicals can damage cells, proteins, and lipids like LDL. This damage contributes to inflammation and atherosclerosis, promoting plaque formation and cardiovascular disease.
Okay, so, that's fair enough. And why is it called the disease of the endothelium?
It's called that because atherosclerosis starts with damage to the endothelium, which is the inner lining of blood vessels. This damage triggers the whole process of plaque formation and inflammation that can lead to cardiovascular disease.
I see. And how is collagen connected to all of this?
Collagen is part of the fibrous cap that forms over plaques. It helps stabilize the plaque, making it less likely to rupture. However, if the plaque becomes unstable, the collagen can degrade, increasing the risk of rupture and clot formation.
I see.
Yeah.
So collagen stimulates coagulation?
Collagen plays a role in the coagulation process by acting as a surface for platelets to adhere to. When blood vessels are damaged, collagen is exposed and platelets bind to it, triggering platelet activation and aggregation. This forms a platelet plug, which is a crucial step in stopping bleeding.
Okay, so if we want to control blood clotting, then we mentioned anticoagulants.
Exactly. Anticoagulants are medications that help prevent blood clots from forming or growing. They work by interfering with the clotting cascade, which is the process your body uses to form clots. Common examples include warfarin, heparin, and newer direct oral anticoagulants like apixaban.
What about antiplatelet agents and fibrinolytics? How do they differ?
Antiplatelet agents and fibrinolytics both help manage clotting, but they work differently. Antiplatelet agents like aspirin or clopidogrel prevent platelets from clumping together, reducing clot formation in arteries. Fibrinolytics, like alteplase, break down existing clots by dissolving the fibrin mesh that holds them together.
Explain this a bit more to me.
Sure. Antiplatelets, like aspirin, stop platelets from sticking together, so they're often used to prevent arterial clots, like in heart attacks or strokes. Fibrinolytics, on the other hand, actually dissolve clots that have already formed by breaking down the fibrin network.
I see. This makes sense. Whereas anticoagulants is about the coagulation factors.
Exactly. Anticoagulants anticoagulants target the clotting factors in the blood, which are proteins that help form clots.
What about the antiplatelet agents then? What are platelets?
Platelets are tiny blood cells that help with clotting. When you get a cut, they rush to the site, stick together, and form a plug to stop the bleeding. Antiplatelet agents prevent these cells from clumping together, which is especially useful in preventing arterial clots.
Wait, so I don't understand the difference. So platelets are not clotting factors. They help them stick together.
Exactly. Platelets help initiate clot formation by sticking together at the site of a blood vessel injury. Clotting factors, on the other hand, are proteins in the blood that work in a cascade to form a stable clot.
So what are some examples of antiplatelet agents?
Some common examples include aspirin, clopidogrel, and ticagrelor. These medications are often used to reduce the risk of heart attacks or strokes by preventing platelets from clumping together.
So how does aspirin work then?
Aspirin works by inhibiting an enzyme called COX-1, which reduces the production of thromboxane A2, a molecule that signals platelets to clump together. By blocking this signal, aspirin helps prevent platelet aggregation and reduces clot formation.
That makes sense. So why does COX is structure allow it to produce thromboxane A2, or its environment? I don't know.
COX-1, or cyclooxygenase 1, is an enzyme that helps produce thromboxane A2 from arachidonic acid.
I don't get it.
No worries. COX-1 is an enzyme that helps convert a substance called arachidonic acid into thromboxane A2, which is important for making platelets sticky so they can form clots. Aspirin blocks COX-1, which means less thromboxane A2 is made, and platelets are less likely to...
So aspirin will it might cause a hemorrhage in extreme cases?
Exactly. Because aspirin reduces clot formation, it can increase the risk of bleeding, especially if taken in high doses or combined with other blood thinners.
Remind us prasugrel and clopidogrel.
Sure, prasugrel and clopidogrel are both antiplatelet agents, similar to aspirin. They block a specific receptor on the platelets, preventing them from sticking together. They're often prescribed for people who've had a heart attack or stent placement to reduce the risk of further clots.
And how does their name relate to their function?
Their names don't directly relate to their function, but they indicate the drug class. Grel at the end suggests they're part of the thienopyridine family.
Well, how am I supposed to remember them if their name isn't... I mean, my name isn't related to me in any way, I guess, which is annoying. But I guess symbols don't have an intrinsic meaning, do they?
Exactly. Names and symbols often gain meaning from context or use. Your name is uniquely yours. Just like these drugs have specific names to help doctors identify and use them properly.
So we talked about anticoagulants. So we talked about warfarin and heparin. Let's talk a bit more about anticoagulants.
Sure. Anticoagulants like warfarin and heparin work by interfering with the clotting cascade, which is a series of steps involving various clotting factors. Warfarin blocks vitamin K, which is needed for producing some of these factors, while heparin enhances the action of antithrombin, a protein that inhibits clotting.
Yeah. What about NOACs?
NOACs, or novel oral anticoagulants, include drugs like apixaban, rivaroxaban, and dabigatran. They directly inhibit specific clotting factors, like factor 10A or thrombin, offering a more predictable effect than warfarin.
What is this dabigatran rivaroxaban?
Dabigatran is a direct thrombin inhibitor, while rivaroxaban is a direct factor 10A inhibitor. Both are NOACs used to prevent and treat blood clots, such as an atrial fibrillation, deep vein thrombosis, or pulmonary embolism.
Interesting. Let me ask you a question now. What websites and apps will let me practice all this knowledge that we've talked about today?
To enhance your medical knowledge, consider using Capsule, which has clinical case-based quizzes. Amboss offers a digital medical library and exam prep tools. ND Calc is great for clinical decision support.
Capsule, what else?
You can also try UWorld. Medscape for articles and practice guidelines.
It's weird. Yesterday I asked you the same question. You gave me other examples. You said up-to-date Visual DX. You said Complete Anatomy, Atlas, Osmosis, Can Help, Figure 1. Now you're telling me different ones. Tell me again the different ones.
Sure. Yesterday I mentioned UpToDate, which is a comprehensive clinical resource. Visual DX for diagnostic support. Complete Anatomy Atlas for 3D models. And Osmosis for video-based learning. Figure 1 is also useful for clinical images. These are all great for different aspects of medical learning.
Yeah, but today you mentioned Capsule, and what are the other ones you mentioned?
Today I mentioned Capsule, which has case-based quizzes. And DCalc for clinical decision support. Next.
Wait a sec, guys. So, just a sec. It said his Capsule, Ambos. Let me write it down. I'm gonna check them out after. And MD Calc. I wonder if these are any good. And I'm spending an hour a day at the moment, guys, just checking different medical apps out. UWorld too. Jesus, there's so much stuff, and I'm sure everything up to now, everything I've checked out, guys, was really fun. So let me just check for a sec. Okay, I'm gonna check these after. Guys, check it out. Let me know what you think too of these. Sorry, we got carried away. Let's go a step back. So, NOAAs. So novel oral anticoagulants. We said dabigatran and rivaroxaban. I don't understand where the names come from, dude.
The names dabigatran and rivaroxaban are derived from their chemical structure and target.
Just a sec. Let's go again. So, nicely and slowly tell me again about dabigatran and rivaroxabans. How does the name reflect their function structure? Don't be shy, sir. Okay, let's ask one more time. I'm sorry, guys. Sir, how does dabigatran and rivaroxaban names reflect their structure and function?
So dabigatran and rivaroxaban are named to reflect their functions as anticoagulants. Dabigatran's name hints at its target thrombin, with gatran suggesting inhibition. Rivaroxaban's XA points to factor XA, its target, and BAN suggests blocking it. Both names help indicate their specific roles in preventing blood clots.
So how does tran suggest blocking it?
Tran in dabigatran doesn't directly mean blocking. It's more about how it binds to thrombin, the enzyme it inhibits. The gatran suffix generally indicates it's a direct thrombin inhibitor. The naming conventions for these drugs help give clues about their targets and mechanisms.
Okay, lastly, fibrinolytics. So, we talked about them a bit, but I want to ask about streptokinase and urokinase.
Sure, streptokinase and urokinase are fibrinolytics, meaning they help dissolve blood clots. Streptokinase is derived from streptococci bacteria and works by activating plasminogen to plasmin, which breaks down clots. Urokinase, originally found in urine, also converts plasminogen to plasmin, but it's produced naturally in the kidneys. Both are used in clinical settings to treat clots, but they have different sources and properties.
Okay, that makes sense. So, let's talk a bit about general anatomy questions that I have now. So, the first one is in regarding to the transpyloric plane. We can see here the regions of the stomach.
Yes, the transpyloric plane is an imaginary line that typically crosses through the pylorus of the stomach around the level of the first lumbar vertebra. It helps identify the pylorus, the duodenum, the gallbladder's neck, and even the hilum of the kidneys.
So the transpyloric plane is between the epigastric and umbilical?
Exactly. The transpyloric plane is roughly halfway between the jugular notch at the top of the sternum and the upper border of the pubic symphysis. It's a horizontal plane that often aligns with the L1 vertebra.
So it's above the umbilical.
Yes, it's above the umbilicus. The transpyloric plane typically lies a few centimeters above the belly button. It's an important landmark for locating various abdominal structures.
I see.
Great. Anything else you'd like to know about anatomical
Well,
landmarks?
yeah, I want to see this transpyloric plane. What does it cut? Well, it cuts through the kidney and the pancreas and the duodenum, yeah?
That's correct. The transpyloric plane intersects several key structures, including the hilum of the kidneys, the neck of the pancreas, and the first part of the duodenum. It's also close to the pylorus of the stomach.
Anything else that it intersects?
Yes, it can also intersect the fundus of the gallbladder, parts of the transverse colon, and sometimes the origin of the superior mesenteric artery. It varies slightly between individuals, but is a very useful reference point.
I see. I want to also ask a bit about arteries, specifically the common hepatic artery.
Sure, the common hepatic artery is a branch of the celiac trunk. It supplies oxygen-rich blood to the liver, pylorus of the stomach, duodenum, and pancreas. It typically divides into the proper hepatic artery and the gastroduodenal artery.
So this picture is from Wikipedia, guys. Thank you to the person that uploaded it. So, wait. So we have the superior mesenteric vein and the common hepatic artery and the portal vein and the proper hepatic artery and the pyloric artery and gastroduodenal artery. How do they connect? I'm so confused.
No worries. The common hepatic artery branches into the proper hepatic artery, which supplies the liver, and the gastroduodenal artery, which supplies the stomach and duodenum. The portal vein is formed by the union of the superior mesenteric vein and the splenic vein, and it carries blood to the liver. Everything interconnects to ensure blood flows to and from the liver, stomach, and intestines.
So, gastroduodenal supplies duodenum and stomach.
Exactly. The gastroduodenal artery supplies the stomach's pyloric region and the first part of the duodenum. It ensures these areas receive oxygenated blood.
Whereas the pyloric is the pylorus.
Yes, the pyloric artery specifically supplies the pylorus, which is the region of the stomach that connects to the duodenum.
Okay, let me ask you a question. Wait. So the proper hepatic artery, where does it come from?
The proper hepatic artery originates from the common hepatic artery. After the common hepatic artery branches off from the celiac trunk, it splits into the proper hepatic artery and the gastroduodenal artery.
Wait a second. This diagram shows the common hepatic artery branching off to two things.
That's correct.
Tell me.
So the common hepatic artery usually branches into the proper hepatic artery, which goes to the liver, and the gastroduodenal artery. The proper hepatic artery then further divides into smaller branches, including the right and left hepatic arteries.
Wait. I think I got it. So we have the common hepatic artery, and then it branches to the gastroduodenal artery and the proper hepatic artery, and then the proper hepatic artery has a branch which is called pyloric artery.
You've got most of it. The proper hepatic artery does branch further, but it's typically into the right and left hepatic arteries. The pyloric region is often supplied by branches of the gastroduodenal artery, like the right gastric artery. Everything interconnects to ensure blood supply to the liver, stomach, and duodenum.
Wow, I'm confused. Is there another picture I could find on Wikipedia?
I totally get it. The anatomy can be tricky. On Wikipedia, you can find detailed diagrams under terms like celiac trunk or hepatic artery. Those will give you a visual breakdown of all the branches and connections.
Celiac artery.
The celiac artery, also known as the celiac trunk, is a major branch off the abdominal aorta. It quickly splits into three main the splenic artery. These branches supply blood to the stomach, liver, spleen, and parts of the esophagus and pancreas.
Okay, let's try and find how they're connected then. So we have the celiac. Jesus Christ, dude. This diagram, I don't like it.
No worries.
This is better. Okay, so we have the hepatic portal vein. This diagram, I like it. Let's use this one. Can we? Are we allowed to?
Absolutely. Let's use the diagram that works best for you.
Alright, so you have the hepatic portal vein, and it branches to the superior mesenteric vein and the inferior mesenteric vein, and the splenic vein.
Close. The hepatic portal vein is actually formed by the union of the superior mesenteric vein and the splenic vein. The inferior mesenteric vein usually drains into the splenic vein before they merge. This combined vessel, the portal vein, then carries nutrient-rich blood to the liver.
Okay, and the common hepatic artery, how is this involved in things?
The common hepatic artery supplies oxygenated blood to the liver, gallbladder, stomach, and part of the duodenum. It's a branch of the celiac trunk and divides into the proper hepatic artery, which goes to the liver, and the gastroduodenal artery, which supplies the stomach and duodenum.
Wow, I'm so confused, dude. I'm so confused. We have to go through it again. Also, before we go through it again, what about the inferior vena cava and the renal veins and the renal arteries? Can we kind of clarify that a bit too?
Sure. The inferior vena cava is the large vein that carries deoxygenated blood from the lower body to the heart. The renal veins drain blood from the kidneys into the inferior vena cava. The renal arteries branch off from the abdominal aorta and supply the kidneys with oxygenated blood.
Okay, and how are they connected?
The renal arteries branch off the aorta and enter the kidneys. The renal veins exit the kidneys and connect to the inferior vena cava. This setup ensures blood flows into the kidneys for filtration and out to return to the heart.
I can see it here. Yeah.
Great.
That makes sense. Okay, if we go a step back then, let's go a step back to the hepatic artery stuff.
Sure, the common hepatic artery comes from the celiac trunk and splits into the proper hepatic artery, which supplies the liver, and the gastroduodenal artery, which supplies the stomach and duodenum. The proper hepatic artery then branches further.
Give me a sec.
Take your time.
Hepatic artery probe. Okay. Let's see. Okay. Hepatic artery. Wow, this is might be a better diagram. Tell me.
The proper hepatic artery usually splits into the right and left hepatic arteries, which supply the liver. It also gives off the right gastric artery to the stomach. Everything is interconnected to ensure proper blood supply.
Okay. I'm gonna do a bigger episode about this, guys. I need to go to the toilet, but I'm gonna set up a live stream very soon anyway on another topic, and hopefully we can cover this. Thank you for listening, and I'll see you all next time.
Sounds good. Enjoy your break